Okay, so our second speaker is Dr. Nicola Meagher, who is a research fellow in the Ovarian Cancer stream at the Daffodil Centre at the University of Sydney, having recently finished her PhD with Professor Susan Ramos at the University of New South Wales. Nikki tells me that she's actually graduating. The ceremony's on Monday, so that's exciting. As part of her PhD, she used data from OTTR, the International Ovarian Tumour Tissue Analysis Consortium, to identify prognostic markers for mucinous ovarian cancer, a rare subtype. And her work contributed to the diagnostic guidelines and better prognostic markers for mucinous ovarian cancer. So I think we're going to hear more about that now. Thanks, Nikki.
Thanks very much, Dale, and thank you for the opportunity to speak. So, I did my PhD over about 5.5 years at UNSW, so I'll be taking you through that in 20 minutes. So all this work that I'm presenting today was done at the University of New South Wales, and it actually just occurred to me this morning that when I was planning my PhD, I was in discussions with Susan and Anna, and it was at this very meeting in 2016 that we actually cornered Michael Friedlander and asked him if he would co-supervise as well. I think he's taken off, but yes, thankfully he agreed straight away. So yes, very special to be back here today. Also acknowledgements to the OTTR Consortium. And I couldn't give a talk about mucinous ovarian carcinoma without acknowledging Kylie Gorringe, who's a fantastic collaborator and leader in this space. So David Botel kindly gave a bit of an overview this morning, but just to reiterate, so mucinous ovarian carcinoma is one of the rarer histological subtypes, just 3 to 4% of epithelial ovarian cancers. Thankfully, the majority are diagnosed at early stage, and those women do very well, but those diagnosed with advanced stage disease have very poor outcomes. One of the issues is that there can be misdiagnosis from metastases with no obvious primary diagnosis. So there's a real need for better diagnostic markers. And a poor response to standard ovarian cancer chemotherapy. There's more recently been a shift towards using gastrointestinal style treatment, but we also need some better therapeutic targets for these patients. So there was one attempt to do a mucinous specific clinical trial to answer the question around using gynecological chemotherapy versus gastrointestinal style chemotherapy that was run about 10 years ago with the aim to recruit 330 patients. But unfortunately, that trial stopped due to slow accrual and also the issue of eligibility. So about half of the patients were found to have metastatic disease and were ineligible. They did a small analysis of the 50 patients that were recruited and didn't find any difference in overall or progression-free survival between the gynecological and GI chemotherapy. There's been some retrospective studies published as well. So this is a small study, about 50 patients going back, again, trying to look at that same question, a trend favouring gastrointestinal style chemotherapy, as you can see. But yeah, in the absence of clinical trial data, this is really the only evidence that can necessarily be guiding clinicians to date. So, through the Ovarian Tumour Tissue Analysis Consortium, I'm very privileged to be able to access the samples and data pooled around the world, which really makes it much more plausible to be able to study rare histological subtypes, doing tumour profiling analysis studies, looking for diagnostic and prognostic markers. So one of the first studies I just wanted to talk about, we published in 2019, that was looking at the diagnostic aspect. So looking at trying to differentiate between primary mucinous ovarian carcinoma and those that have spread from the lower gastrointestinal tract. So low-grade appendiceal neoplasms and colorectal cancers can spread to the ovary, mimic an ovarian primary, and make it very difficult for pathologists. So the marker called CK7 by immunohistochemistry is routinely used by pathologists, but we wanted to see that if you added a marker called SATB2 to the diagnostic algorithm, would that improve things? So we found that if you use CK7 and SATB2 in combination, so a CK7 positive and SATB2 negative tumour is more likely to be a primary mucinous ovarian cancer, but the reverse of that, more suspicious for a gastrointestinal metastases. And we found that with about 95% accuracy. So in this paper, we provided a decision tree for pathologists, and this work's been cited in some of the international clinical guidelines for diagnosis. So that helps with lower GI metastases. There's still a lot of work to be done for the upper gastrointestinal tract. So now moving on to prognostic biomarkers. So from diagnosis to prognosis, we did a big gene expression profiling study. So this was using nanostring. We had a panel of 19 genes, and this was looking at mRNA expression in the tumours. So we had tumour samples submitted through the consortium with pathology review and clinical data from about 18 studies around the world. We had primary mucinous ovarian carcinomas, some borderline tumours, and primary and metastatic lower gastrointestinal, appendiceal, colorectal, and pancreatic and gastric cancers. We were testing to see if we could identify an mRNA expression gene set to help with the diagnostic classification, and also assessing for markers associated with prognosis in this study. So, spoiler alert, we failed but we couldn't identify a diagnostic classifier, so there's still really an area of need there. But we did identify some markers associated with prognosis, so I'm going to focus on that now. So amongst the genes, we found, that box is in the wrong spot, but 2 genes that were associated with prognosis. So high expression of the top one, thrombospondin 2, and the second one, transgelin. So high expression of those genes in the tumours. Those patients had poorer overall survival, and that was after adjustment for age and stage and stratification by study. So thrombospondin 2 is a glycoprotein. It's been shown to have a role in tumour growth, angiogenesis and metastases. And transgelin's an actin-binding protein associated with migration and invasion. And both of these genes were also upregulated in patients with advanced stage disease. Another important feature that we need to talk about when we think about mucinous ovarian carcinoma is the pattern of invasion. So there's 2 described patterns of invasion. So on the left is an expansile or confluent pattern of invasion, and then on the right, an infiltrative or destructive. It's much more destructive and haphazard through the stroma. So these have been described previously, and some studies have shown a higher risk of recurrence in patients. It's particularly of importance women with stage 1 disease, where have a higher risk of recurrence, but those studies have been fairly small and often unable to do multivariate analysis. So we wanted to look at this in our relatively larger cohort. And why that's important, particularly for stage 1, is when we're thinking about the application for treatment. So these are the guidelines from the US, the NCCN guidelines, that recommend for all patients with stage 1A and 1B mucinous carcinoma that following surgery they are just observed. Whereas the European guidelines, so these are the ESMO guidelines, these are a little bit more nuanced and take into account the pattern of invasion. So they recommend that patients with 1A or 1B with an infiltrative pattern of invasion should be offered adjuvant chemotherapy. So just some variation internationally there. So this is what we saw. So this is all all patients with pattern of invasion data. You can see the expansile and in the red, and the infiltrative, women with infiltrative pattern of invasion had poorer overall survival. So this is an unadjusted analysis. And then when we look just at the stage 1 patients, because that's where we thought it really would have the most sort of clinical relevance, you can see there's no statistically significant difference between those groups. But what you do see, if you look just at the start of the curve in those first 2 years, there really is quite a sharp drop for the patients with stage 1 infiltrative pattern of invasion. So we wanted to look at that a little bit more closely. And so we did a time split analysis. So basically looking at the period in the 2 years from diagnosis. So this is women with all stages. That's just the overall results. And then when we stratify by time, it's a little bit busy. But so just looking in the first 2 years from diagnosis, for both all stages and for the stage 1 patients, you can see there's a 3-fold increased risk of mortality for those patients with an infiltrative pattern of invasion. And then and the period after 2 years is not significant. Interestingly as well, you recall the 2 genes that I mentioned that were associated with poorer overall survival are also upregulated in this infiltrative subtype. And thankfully this is something that Kylie is looking at a bit further in her lab. So what about treatment? What about targeted therapies? So Kylie's done a lot of work in this space, some of the clues from molecular studies. We know that these patients have high rates of KRAS mutations, HER2 amplification in about a quarter of patients. There's PIK3CA mutations and BRAF mutations. As you saw from the chemotherapy trial, it's very hard to do clinical trials in these patient populations, so we really need different approaches for these rare subtypes. There are certainly phenotypic and molecular similarities with pancreatic cancers. So I believe that we need a bit more focused effort in collaborating with pancreatic cancer researchers, looking at basket-style clinical trials, and working closely, because there really is a lot in common between those cancer types, and that could be an area of future work. As David mentioned earlier as well, these patients have very low frequency of homologous recombination deficiency, so PARP inhibitors are very much unlikely to be of benefit. We know there's low frequency of mismatch repair deficiency and low tumour mutational burden, so probably not a role for immune therapies. But at this point, we weren't really sure about that and wanted to look at that in a bit more detail. So that takes me to the third and final study that I wanted to tell you about, looking at immune profiling in these patients. So this was a collaboration with MOCOG, the Multidisciplinary Ovarian Cancer Outcomes Group, which many of the investigators are here in the room. So this was doing immunohistochemistry and immune fluorescence to look at the immune markers and see what's happening in the immune infiltrate in these tumours. So we use bright field immunohistochemistry and immune fluorescence, and this is just showing you an example of some of the markers that we're able to look at, the densities in the epithelium and in the stroma of these tumours. That's just a list of the markers that we had available to us on the panels. So a couple of things that we observed. So we saw variation in the types of tumour-associated macrophages in these patients. So patients with advanced stage disease had higher levels of PD-L1 negative macrophages and lower levels of PD-L1 positive macrophages. So one of the things that we sort of hypothesised from this is that perhaps the PD-L1 negative macrophages represent the sort of pro-tumorigenic kind of M2 phenotype of macrophage, and perhaps that's one thing that's driving a sort of immune hostile environment for those patients, for those tumours. doing a clustering analysis, so looking at all of the different markers in the epithelium and in the stroma. We sort of identified about 4 clusters, but really these tumours would be considered to be immunologically quite cold, low levels of PD-L1 and CD8 T cells. About 14% in our cohort could be considered immune inflamed and hot, and I think the next talk is going to probably focus a little bit more on immune profiling, and we'll make that a bit more clear, but in this cohort it's really not looking like a particularly immunogenic environment. We didn't see any association between those clusters and survival. We did see that high density of T regulatory cells were associated with poorer prognosis, which is something that's been seen in high-grade serous as well. So, in summary, so back to the diagnosis, SATB2 is a useful marker in combination with CK7 for diagnosis of lower GI metastases, but again, we do need some more work differentiating between upper GI metastases. Thrombospondin 2 and transgelin are associated with prognosis, and thankfully Kylie's doing some work to see whether that translates to the protein level and whether there's any kind of therapeutic opportunities that can be taken from this work. There's probably a role for adjuvant chemotherapy in patients with stage 1 infiltrative disease, and collection of that data and prospective validation of this type of work is very, very important to take that forward. Mucinous ovarian carcinomas are immunologically cold, and the current generation of immune therapies are unlikely to benefit. So if there was ever going to be an opportunity for immune-based therapies, it would need some sort of combination approach, hopefully in the future. And as you can see, rare histotypes are challenging. There's strength in consortia. I think, as I mentioned, basket-style clinical trials that don't necessarily focus on the tumour site of origin, but are looking more at the molecular targets are the way to go, and certainly that would be the case for this rare histotype. Thank you to my supervisors and many collaborators all around the world. I've been very fortunate to work with lots of wonderful, clever people. So thank you.
Thank you very much, Nikki, for that wonderful talk. And I think we've got 10 minutes for questions, so we'll keep you up here for 10 minutes.
Yeah.
No, not really. Are there any questions for Nikki? I've got a couple, so maybe I'll start. So was it ERB-B2 that was it higher expression in your mucinous cohort was associated with a better survival? Did I see that in the table?
So in an unadjusted analysis, that didn't hold up. So with HER2 we saw about a quarter of patients had HER2 overexpression, and we had a smaller subset where we had amplification data. It's seems to be more common in the lower stage disease rather than the advanced stage disease. So in terms of HER2 as a therapy, that might be a challenge only for a smaller proportion of patients.
And congratulations on getting over 600 patients in that study.
Oh,
that was amazing.
It helps when you combine with GI tumours that are a bit more common, but yeah.
Yeah, sure. And the other thing I wanted to ask about the immune analysis. So I think maybe some of those subtypes didn't associate with survival like you would expect, like the ones with TILs weren't necessarily longer survival. So are we finding the right immune markers? Maybe something else is going on?
Yeah, I don't know. You would probably know better than I, but certainly the group that were the hot tumours, they also tended to be sort of there was no stage association, there was no kind of correlation with the pattern of invasion. So yeah, it's very difficult to kind of tease out.
And I guess that was on Team A's. So
Yeah.
we might need to look at
Sure, yeah.
more samples, I
Yeah.
suppose. Yeah. Any questions from the room? We've got 10 minutes.
Don't feel
Oh, there's
obliged.
one at the back.
Thanks for your talk. Would you mind talking a little bit more on the anti-angiogenic pathway with the mucinous? Did that come out as being something of importance?
It's not my area.
Just thinking because with GI tumours,
Yeah. So I'm not really familiar with markers on the angiogenic pathway. Can you tell me what some of them are, and I could tell you whether?
In terms of anti-VEGF agents, but I suppose because
Yeah.
bevacizumab, we're using it more widely now. So I was just curious on whether there was any signals with interaction with what you found.
Yeah, not something that we were looking at in our gene selection, was there, Anna? No, I don't know whether Kylie. I don't think it's come out really in Kylie's work. So, yeah.
I think Kylie's thinking about, given the difficulties in running clinical trials, is trying to collect data from real-world patients and seeing whether sort of aggregating just, experience from different clinical centres gives an insight into what might work better. Do you have any thoughts about that approach?
Yeah, definitely. I mean, I've chatted to Kylie about this. She's sort of looking at some of the bigger kind of trials, like the NCI match trial, and just getting little pools of data out of each and combining them together. Might be one way to look at things. But I guess if we want to sort of, prospectively kind of answer questions specifically with mucinous in mind, it's very tricky. Yeah.
Any other questions? Yep.
Thank you for your talk. This is more like to ask a surgical question with these patients. Obviously, there's been a lot of talk about in the GI field about high-PEC and treatment of advanced mucinous carcinomas, and a few of the units are talking about complete cytoreduction and delivering high-PEC into the abdomen. And obviously, it's a fairly sort of newish treatment of that, and I don't know how much data is there or whether in the clinical details that you collected with the patients, was there any sort of benefit to using that kind of treatment in these patients?
So I know that I think it's in Chicago, Michael Frumovitz and Katie Kernett, they're running a high-PEC trial in advanced mucinous cancer. I don't know how far along that is and how long we're going to have to wait for some results from that. But yeah, I mean, certainly when you think about the similarities with appendiceal cancers, for example, which is obviously where high-PEC is used, as far as I know, one of the kind of more successful cancers in terms of high-PEC. That kind of points to a potential, but have to wait and see what results come out of that trial.
Cool. Okay. Any more questions?
I should have put some more slides in and
Yeah.
spoken for longer, shouldn't I?
It's always been like a
Long
second
time.
PhD thesis defence.
Defence,
Thank you very much, Nikki. That was
Thanks,
great.
yeah.